So, thank you very much, Professor Kakar, and thank you for asking me to speak. I am a general practitioner from the UK, and I lead the UK recruitment for the GARFIELD study. I have to give my disclosures. That's what one has to do these days. As you will see, I will work for anybody. So if there's any drug companies out there who I haven't worked for, please come and see me afterwards. I'm not fussy. Now, I'm going to move on from what Professor Kakar mentioned about the value of registries. I'm going to try and put into context why registries are important. I would just like you to take a couple of seconds to look at this slide, because we've known for a long time that anticoagulation is probably the most important intervention we can do as doctors for patients with atrial fibrillation. There is nothing as powerful as anticoagulation in stroke prevention for atrial fibrillation. It reduces one's risk of stroke by 2/3. Now, there is nothing in medicine that is as powerful as that. It reduces one's risk of mortality by 1/4. There is nothing in medicine as powerful as that. And we know that from randomized controlled trials. So what I'm hoping to show in the next few minutes is that registries hold a mirror up to us as clinicians as to what we do, not what we say we do. And it strikes me as almost a no-brainer, to use the American phrase, as to why we aren't using anticoagulation more. Now, I'm going to show a couple of slides that AJ's already shown. These are data, I think it's the only data I'm going to show from GARFIELD baseline data. And what this shows is two things. That patients who are at low risk of stroke, we are over anticoagulating. And patients who are at high risk of stroke, we are under anticoagulating. And if you remember nothing else from this symposium, that's what you should take home. We are using anticoagulation inappropriately. We are undertreating those at low risk, i.e. with a CHA2DS2-VASc score of 0. And we're undertreating patients with high CHA2DS2-VASc scores. And that, to me, is very depressing, because this evidence has been around for a long time. And it beholds us all to think on why we are doing what we're doing. So even all patients, only 50% of our patients are getting anticoagulation. However, anticoagulating patients with a CHA2DS2-VASc score of 0, who have minimal risk of having a stroke, our rates of anticoagulation are 40%. Yet patients with a very high risk, i.e. a CHA2DS2-VASc score of 5 or more, only 50%, 60% of our patients are getting anticoagulation. So there's something strange going on here. There's something odd about how we implement the evidence that's before us. So why is a registry important? Evidence generally comes from level 1 data, as again the Americans like to say, randomized controlled trials or synthesized data from. And within randomized controlled trials, you get selected populations, and you're mainly looking for efficacy balanced against safety. And of course, you have to follow good clinical practice. Within registries, we're really looking at the real world. We're looking at the things that happen out there, not what we say happens out there. It affords you the chance to look at large populations, and in particular in the UK, we're taking patients from primary care who are managed by all sorts of people. So it's a generalizable population. It's not the optimal. There are limitations to randomized controlled trials, as we all know. We tend to exclude patients who are at high risk of bleeding. We tend to treat patients better within randomized controlled trials, particularly in terms of perhaps warfarin control. There still remains some uncertainty in the 65 to 75-year-old population, which is about 20% of those with AF. And whilst guidelines are explicit about the use of anticoagulation, there's still mention of aspirin. And again, aspirin has no role in the treatment of stroke prevention in atrial fibrillation. So registries afford us the opportunity to look at what happens in real life, what we do, not what we say we do. It allows us to track what physicians do. It allows us to look over time, and the beauty of the GARFIELD Registry is it's at the cusp of the introduction of new agents, so we will see what happens in terms of how new agents are introduced. It allows us to look at why physicians choose to do what they do, and that's something we'll be doing in the later cohorts. And it allows us to look at how physicians actually implement what is a very robust evidence-based. However, it's non-randomised. So we're taking all comers, and I think that's a strength rather than a weakness of a registry. We're taking all comers. So everybody who has atrial fibrillation is entered into the registry, irrespective of what their treatment decisions were. And we're trying to reduce bias by having every patient who comes along gets entered into the study. So, what does a registry do? It gives us an understanding of real-life management of atrial fibrillation across a worldwide database. That, to me, is the power of GARFIELD. We know that clinical trials are the bedrock of the evidence that we produce, but they don't necessarily reflect what we do in real life. So what registries can do is provide us with an insight into the epidemiology. We can look at the actual stroke risk of patients as they go along. We can look at recurrence and mortality, and we can look at the actual use of anticoagulation and antiplatelet therapy, or indeed no therapy. We can also look at bleeding complications and look at the comorbidities. Now, you have to say, does GARFIELD reflect what was in the randomised trials? Well, pretty much it does. The only real difference is that the ROCKET trial, which was rivaroxaban, had a higher risk population than we have. And in fact, most of the studies had a higher proportion of patients with hypertension than we have, which simply reflects the real world versus who gets into a randomised controlled trial. But we have to reflect upon that, and we have to accept that our population is similar but different. And that's good, because that's telling us what we actually do, not what we would do in a randomised controlled trial. So, GARFIELD is the biggest registry of its kind. It will provide the first ever picture of the real global burden of atrial fibrillation, as opposed to that we find from randomised controlled trials. It will, as I say, I like the image of a mirror reflecting on us what we do rather than what we say we do. And it will also tell us how we're introducing these new agents into clinical practice. It will offer a global and national perspective into AF patient profiles. And I'll just stop for a second. We're only part way into the GARFIELD Registry, and already we're raising questions about what we do. I thought the UK would be fantastic. I thought we'd be much better than the rest of the world in what we're doing. We're exactly the same. We still have underutilisation of anticoagulation in high-risk patients and over-anticoagulation of low-risk patients. So it's already throwing up questions. It probably won't provide answers, but it will throw up questions. We're seeing prescribing habits, and we are going to explore with physicians why they're doing what they're doing. And it's going to assess the application and effectiveness of the current treatment guidelines, particularly looking at the risk scores, so CHADS-2 and CHADS-VASc. It will identify gaps. It will identify how we're implementing therapeutic strategies. It will identify what the key cost drivers are. But most importantly, we're going to identify what the communication issues are. Why is this robust evidence base not being utilised in the real world? Thank you very much.
David, thank you very much indeed. I think we'll take questions, if we may, at the panel discussion session, and move on to our second presentation now, which is to be made by Professor Graham Turpey, who is Professor of Medicine in McMaster University in Ontario in Canada, and he's going to talk to us about